What is cholecystitis? Why do we get cholecystitis? What is the pathophysiology? How do we make the diagnosis? What are the signs and symptoms we look for in a patient with cholecystitis? What is Murphy's sign? Who was Murphy? How about important labs, important imaging techniques like ultrasound or a HIDA scan? We're going to go through everything about cholecystitis in part 1 today, the pathophysiology, what it is, and how to make the diagnosis. Let's do it. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. Today we're talking about cholecystitis. This is an incredibly important topic. I've taken out 2 gallbladders in the last couple of weeks, and it was important that I knew how to take that history, do that physical exam, look at the correct labs, get the appropriate imaging, make the diagnosis so that I could initiate a treatment plan. If you like this content, make sure to give it a like, give it a share it with your friends, leave a comment, let me know that you are finding value. But let's get right into it. And what do I like to start with? I love to ask why. So why do we need to know about cholecystitis? Well, like we talked about in that gallstones video, I highly recommend you check that out. Really good content there. But in that video, I said, well, there's about 10 to 15% of the population that has gallstones. And in those people, about 20 to 40% of those people with gallstones can have complications. Now, those complications could be cholecystitis. It could be a gallstone lodged in the common bile duct, so choledocholithiasis, or it could be something like acute pancreatitis or even ascending cholangitis. So for those reasons, it's really important that we understand the various complications associated with gallstones, be able to make diagnoses, be able to initiate treatment plans so patients don't suffer from morbidity and even mortality of these complications related to the gallstone. Now that we see how common this is in our population, there are some important things to consider. So number 1 is that it can occur in all ages. So unfortunately, I've seen an increased rate of cholecystitis in young people as a pediatric surgeon. It's increased in women, it's increased in obesity, it's also increased risk in pregnancy, and it's important to consider that surgery is a safe and effective treatment if performed by an experienced surgeon, okay? So some important things to consider with cholecystitis. Now, how do we define cholecystitis? Well, cholecystitis, all right, the itis means inflammation of the gallbladder. And there are 3 basic things that I look at when we have inflammation of the gallbladder. We can have acute calculous cholecystitis, so that's cholecystitis or inflammation caused by gallstones, okay? We could have acute acalculous cholecystitis, so that's inflammation of the gallbladder without gallstones, okay? And I'm going to talk about that at the very end of the video, so make sure to stick on because that's a really important diagnosis that we sometimes have to make in critically ill patients. And then third is chronic cholecystitis, but today we're really going to be focusing on acute calculous and acalculous cholecystitis. Now, why do we get cholecystitis? So you can see in this cartoon right here that gallstones, from that previous video, and I highly recommend you check that out, all right? So gallstones can cause complications in many different areas. So they can obstruct the cystic duct, okay? That can cause acute cholecystitis. We're gonna talk about that. They can obstruct the common bile duct. That can cause ascending cholangitis or just elevated bilirubin and jaundice from an obstructed bile duct. They can obstruct the pancreatic duct, and that could lead to acute gallstone pancreatitis, all right? So what is the reasons or why do we get cholecystitis? Number of reasons here, but first is obstruction of the cystic duct, usually from a gallstone, can also be from sludge, okay? Second is because we have bile stasis from that obstructed duct, now the gallbladder cannot empty, we're going to get an infection of that static fluid, okay? And then third, if the pressure starts to develop and starts to increase inside the gallbladder, just like in appendicitis, we can start to get mucosal ischemia, and that's going to start to lead to a vicious cycle and get worse and worse for that patient. Now, in that video on gallbladder anatomy, we talked about the gallbladder mucosa. We talked about why that it is sensitive and that it is at increased risk of infection. So why is that? Well, it's exposed to bile. Now, bile is a digestive fluid. We talked in that video what bile is, and that is kind of a caustic fluid to digest things, okay? In addition, the gallbladder mucosa doesn't have a very thick protective mucosal layer. 3, it has a poor blood supply. And finally, it is constantly exposed to different pressures, and that causes injury to the mucosa. So these are all the reasons why the gallbladder mucosa is sensitive to inflammation. So now that we understand why we get cholecystitis, okay, obstructed bile duct from either stone or sludge, now we get bile stasis, we're going to get superimposed infection, increased pressure, ischemia of the mucosa, going to start this vicious cycle. It's going to get worse and our patient's going to get sicker. How do we make the diagnosis? All right, well, let's start with our patient. So we got this guy here, he's got pain. Well, what is he going to have? He's going to have symptoms and signs. And so we take a history and physical exam. So what are the really important parts of the history that are very specific to cholecystitis? Well, we talked about how to take a history in previous videos. I'll put a link to that up there. But we want to do our SRN OPD SARA approach. So site, radiation, nature, onset, periodicity, duration, severity, aggravating, relieving, and associated. Okay, ask those 10 questions. That's going to give you a great history of presenting illness. And here I have, with likelihood ratios, the symptom and how that's tied to making the diagnosis of appendicitis. So the most common things are having constant right upper quadrant pain, all right, nausea, and a loss of appetite. You know, if we have those 3 things as symptoms, okay, in the subjective, then we can start to direct our thought process in this patient presenting with abdominal discomfort towards acute cholecystitis. All right, well, what signs are most important? So the signs that are most important with their associated likelihood ratios are fever, all right? Second is right upper quadrant tenderness. We're going to talk about Murphy's sign in a minute. Now hold on, okay? Tachycardia, so increased heart rate, and tachypnea, increased respiratory rate, okay? So when we do our history and then our physical exam, if we see these things, now we can even start to go in closer, start to focus even narrower on a diagnosis of acute cholecystitis. So I said it, Murphy's sign. So what is Murphy's sign? How do you elicit Murphy's sign? Right, well, Murphy's sign is respiratory arrest with palpation in the right upper quadrant on inspiration. So a patient with cholecystitis, if we press right at the, where? Tip of the 9th costal cartilage. Okay, you press right at the tip of the 9th costal cartilage. I'll ask the patient, hey, take a deep breath. Oh, they're going to hurt when they take a deep breath because the liver's coming down. Now the gallbladder is going to touch your fingers. That's going to hurt and they're going to wince. Okay, and that is eliciting Murphy's sign. Now, it's not just feel in the belly, because if you felt in the left upper quadrant, you shouldn't feel, there shouldn't be any tenderness on inspiration. So it's specifically on that right side. Now, the second question is, who was Murphy? So Murphy is an American surgeon, John Benjamin Murphy, from Irish descendants. He was a tall guy, big red beard, and he was known by William Mayo, who is another great when it comes to surgery and medicine in the 19th century, said that John Benjamin Murphy is the surgical genius of our generation. All right, now when you look at this, and I'll put a link to his kind of bio in the description below, but John Murphy was like the perfect general surgeon. So he described techniques in orthopedic surgery, in general surgery, in gynecology, in neurosurgery. So this was back when surgeons were really defining their field, and they operated in every cavity of the body. Nowadays, we are much more specialized. Even within our subspecialties, we have super subspecialties. So definitely check out John Benjamin Murphy, definitely a pioneer. I mean, the guy was trained by Bill Roth, all right? So definitely a pioneer when it comes to general surgery. All right, so let's get into labs. So typically when we have a patient with acute abdominal pain, we're going to get a range of labs. So we're going to get a complete blood count. We're going to get a BMP. We're going to get some liver blood test as well, all right? And we're going to get a CRP or C-reactive protein to look for inflammation. So what labs kind of are most important when it comes to making the diagnosis of cholecystitis? Well, we see here that an elevated white cell count and an elevated C-reactive protein are most consistent with acute cholecystitis. Now that doesn't mean the other labs aren't important, but these are the two that really point you towards a diagnosis of cholecystitis if it fits with your history and physical exam. Now, what other labs are important? I mentioned that briefly, and I want you to hold on a few minutes because we're going to talk about it in a little bit. First, I want to point you to this paper. I'll put a link in the description. This covers the guidelines for making the diagnosis of cholecystitis. It talks about findings in the history. It talks about labs. It talks about all of the imaging. Put a link. It's a free PDF, so definitely check that out. We're going to go through these guidelines today, and one important first message is that no single clinical or laboratory parameter is going to give you the diagnosis of cholecystitis. So history and physical exam, labs, they're very important, but you have to take it all together to make that diagnosis of cholecystitis. And what's going to help you? Imaging is going to help you. Okay, so in this little guy right here, we have signs, we got symptoms, we got labs, and finally we have imaging. When we look at our options for imaging, there are a lot, right? And what is the preferred initial imaging strategy for making the diagnosis of cholecystitis? It's ultrasound, okay? So ultrasound has a sensitivity and specificity of 81 and 83%. Okay, it is operator dependent. Okay, so it's not just like a CT scan. It is operator dependent. They got to get the right images so the radiologist can make the diagnosis. And why do we like it? We like it because it's widely available. It's not very expensive. It's not invasive, and there's no radiation. Okay, so all of these things would get a big thumbs up for ultrasound as a preferred initial imaging strategy to make the diagnosis of cholecystitis. So what can cholecystitis look like on ultrasound? So take a look at this image right here. You can see this is the gallbladder in the center of the screen. And what do we see? We don't see really any shadowing stones. You know, they're going to be probably in another slice of that ultrasound, okay? But what do we see? We see thickening of that gallbladder wall. And I have this kind of outlined with these railroads. So that's one finding. Well, what are the other findings to make the diagnosis on ultrasound? So the findings we want to look for to make the diagnosis are a wall thickness of greater than 3 millimeters. We have wall edema, okay, and that's from that ongoing inflammation. If we have gallbladder distension greater than 40 millimeters or 4 centimeters, we're also going to look for a positive sonographic Murphy sign, okay? So when the transducer is in the right upper quadrant, if there is tenderness there, that's a positive sonographic Murphy sign. We also want to look for pericholecystic fluid, okay, fluid around the gallbladder, or perihepatic fluid, and we can call that the C sign. So these are all the ultrasound findings that we would look for to make a diagnosis of acute cholecystitis. So if we're still struggling, all right, and we can't make the diagnosis, there's not a lot of gallbladder edema, but the patient has a great history and physical exam. In our labs, we have elevated white cell count, elevated CRP, and we're still worried, what other imaging technique is helpful? Well, the technique that has the highest sensitivity and specificity is a HIDA scan. So that's hepatobiliary, okay, aminodiacetic acid scan. Now, what is that? That is when we take radio-labeled 99 technetium labeled aminodiacetic acid. That's given to the patient, and that's where we take a series of images up to 60 minutes, and we look at how that radio tracer travels from the blood to the liver and then concentrating within the biliary tree. Now, normally we should see radio tracer uptake within the gallbladder after about 10 minutes. If we don't see that, we wait until the full 60 minutes, and here we can see there's an absence of radiotracer where we expect the gallbladder be. And what does that mean? That means radiotracers in the liver coming down the biliary tree. It's going to try to go up through the cystic duct, but it can't because the cystic duct is obstructed in cholecystitis, so the gallbladder can't fill with this radiotracer, okay? And that makes the diagnosis of acute cholecystitis, or an absent gallbladder if the gallbladder's already been removed, okay? But in this context, using it to diagnose acute cholecystitis, that would be the finding. I'll talk about this in the next video on symptomatic cholelithiasis or biliary dyskinesia. We can also use the HIDA scan with CCK or cholecystokinin to look at the ejection fraction of the gallbladder when we give the CCK hormone. And we're also going to be looking at any symptoms that the patient has when we give that hormone. So that's another use of the HIDA scan when it comes to gallstones. Okay, and we're going to talk about that in another video. But for today, if we don't get uptake of the gallbladder after 60 minutes, then we can say the patient has cholecystitis. So now you should be in a position where you can fairly confidently make a diagnosis of cholecystitis, okay? We have our history, we have our physical exam, our labs, our imaging, all right? And now we have to ask some questions. So what's a really important question that every surgeon wants to know after a diagnosis of acute cholecystitis? Well, are there associated common bile duct stones? Okay, am I going to have to do a laparoscopic exploration of the common bile duct? Does this patient need an ERCP before I take their gallbladder out, or even after I take their gallbladder out? Do I need to perform an intraoperative cholangiogram? So these are all questions that I'm going to ask the surgeon. And so now I'm going to tell you, how do you answer those questions? So the first thing is the guidelines recommend against using liver blood tests or liver function tests as the sole indicator of common bile duct obstruction. Now, part of that is the fact that patients that come in with cholecystitis or even symptomatic cholelithiasis or symptomatic gallstones many times will pass stones in that episode, okay? So a stone goes through the cystic duct, temporarily obstructs the common bile duct, and then is passed through the ampulla vater into the small intestine and then out through the feces, okay? And they don't have the common bile duct obstruction. And so if you did an ERCP or if you did a common bile duct exploration, you may be over-treating that patient. So we don't want to use just labs, all right? So what else can we use? So we don't want to use just labs, but and this goes back to the other labs that are important. But if you did need to look at the labs to make yourself concerned, what labs would be most helpful? So when we look at liver blood tests, we're going to get a bunch of different labs, okay? We're going to get total serum bilirubin. We may fractionate that into direct bilirubin and indirect bilirubin, okay? Remember that obstructive jaundice is going to lead to an increase in your direct bilirubin, okay? We're going to get AST, we're going to get ALT, we're going to get alkaline phosphatase and GGT, okay? Well, which of these are really helpful when it comes to looking at a diagnosis of an obstructed bile duct? Well, the ones that are most helpful are your alkaline phosphatase and, of course, your total bilirubin. GGT can also be helpful. But why is alkaline phosphatase helpful? Well, alkaline phosphatase is synthesized in the biliary epithelial cells, and so when we get obstruction of the bile tract, we get an increased production of alkaline phosphatase, and that kind of goes into the serum and leading to increased levels. So that is one thing that's going to go up if we have an obstructed bile duct. Second is bilirubin. Now, I'm going to have some specificity numbers here, looking at levels of bilirubin or levels of alkaline phosphatase and the probability that your bile duct is obstructed. So if the total serum bilirubin level is greater than 1.7 milligrams per deciliter, we're looking about a 60% specificity when it comes to your bile duct being obstructed. If it's greater than 4 milligrams per deciliter, then we're looking at a 75% risk of the bile duct being obstructed. And your alkaline phosphatase, if this is more than double the upper limit of the normal range, then you have nearly a 97% risk of a stone being in the bile duct. So if we don't want to use just labs, what can we use? Well, we can use imaging. And what imaging do we have available after we just diagnose that cholecystitis? Well, we have ultrasound, okay? So what do we look for in ultrasound? The best finding on ultrasound is direct visualization of a stone within the bile duct, okay? Now, the guidelines recommend against just using dilation of the common bile duct as a presence of stone. The best is if you can actually see a stone within the bile duct. Now, sometimes we can't see a stone, but we can see that the bile duct is dilated. So how do we use that information? Well, we ask ourselves, what tool is the best to stratify the risk of common bile duct stones, so the CBDS, okay? Well, that is the SAGE's criteria. That is the SAGE's guidelines, okay? And well, what do they say? Well, they say that there is high, medium, and low risk of having a common bile duct stone, all right? Well, what are the criteria for each of these risk levels? So high risk is if you can actually see a stone in the duct on ultrasound, okay? That's high risk. Moderate risk is if we have a total serum bilirubin greater than 4 milligrams per deciliter, or we have a common bile duct that's greater than 6 millimeters and a total serum bilirubin that is between 1.8 and 4 milligrams per deciliter. What is low risk? Well, low risk is if you don't have any of these predictors, all right? So how do we use this risk profile? I'm going to tell you in 1 second. So we have this cartoon here, blue circle. We're worried about a stone in the duct. If we're high risk, then that patient is either going to need a preoperative ERCP or a postoperative ERCP, okay? Or a laparoscopic common bile duct exploration, okay? If we have moderate risk, we need more imaging. So that could be getting an MRCP. That could also be an endoscopic ultrasound, or it could be an intraoperative cholangiogram or an intraoperative ultrasound, okay? So either of those can give us some more information on if we have an obstructing stone. And if we have low risk, we don't need an MRCP or an intraoperative cholangiogram or any other additional modality, all right? So that's how we use this risk profile in determining the management strategy for our patient preoperatively. Lastly, acute acalculous cholecystitis. So what is this? Well, this is inflammation of the gallbladder without stones, okay? You probably got that one. And the typical story is going to be, let's say you have a 72-year-old female who is a victim of trauma, severely ill in the ICU, and now they start to get septic. So you're doing your workup for sepsis and you get an ultrasound, and what do you see? You see this, a severely thickened and inflamed gallbladder. Look at that gallbladder wall. I mean, it's like over 1 centimeter or 2 thick, okay? Well, this will help give you that diagnosis of acute acalculous cholecystitis, all right? Well, why does this happen? This typically happens because we get stasis of the gallbladder. The cystic duct can be obstructed, but we get gallbladder stasis because the patient is so critically ill. We're going to have increased pressure within the gallbladder, and then much like in acute appendicitis, with that increased pressure, we're going to get mucosal ischemia, and that is going to worsen and worsen until the gallbladder becomes necrotic, okay? Now we see that pathophysiological cycle in acute acalculous cholecystitis. And in addition to that bile stasis and ischemia building up pressure, we're going to get a superimposed infection, okay? And so that is going to make things much worse and cause that sepsis, or even septic shock in our patient. So what are the risk factors for this? So shock, septic shock, severe trauma. Also see this in long-term fasting. Total parenteral nutrition for a long time can give acute acalculous cholecystitis. And systemic infections like typhoid fever has been known to be associated with acute acalculous cholecystitis. So we make the diagnosis in much the same way, but in the symptoms and the signs, the history, these are kind of the risk factors that we want to look for. Make the diagnosis on ultrasound. If you can't, you can make it with a HIDA scan and even a CT scan of the abdomen. If you're working up an acute abdomen in a severely sick or shocky individual, then you may see that thickening of the gallbladder wall associated with acute acalculous cholecystitis. All right, so today we talked about cholecystitis. I hope you got a great understanding of what it is, why we get it, and why it's important to understand it. And then, of course, the signs and symptoms to look for, as well as the diagnostic strategies and the guidelines. I'm going to put a ton of stuff in the description below, so check those out. Also check out Citizen Surgeon. I got a lot of great value on there, and I put the show notes to each of these talks in that video, and I'm building that week after week, give you the best value that I can. If you have any questions, comments, leave them down in the comments below. I love interacting with you guys. And next time we're going to be talking about symptomatic gallstones. We're going to do a whole series on biliary problems, and then we'll get into another portion of the GI tract. So I hope you stick with me. As always, study hard, stay safe, and I will see you next time.